Welcome to JBJS OrthoCorps. Listen as members of the ortho community, residents, surgeons, educators, staff, and patients share their stories about the experiences and people most important in their lives and the lessons they learned along the way. OrthoCorps is an audio archive inspired by StoryCorps and independently organized by the Journal of Bone and Joint Surgery.
Hello and welcome to another edition of JBJS's OrthoCorps. I'm Sanjeev Sabharwal here in California, and today I have the distinct pleasure of talking to my dear friend, Dr. Benjamin Joseph. Benjamin is an adjunct professor in southern India at Kasturba Medical College in Manipal, Karnataka. And Benjamin, you're 13 and a half hours ahead of us. So it's morning your time and, my evening. So welcome. And I know we've known each other for, I think, almost 20 years. And I've been a big fan of yours since young attending. And, I've always looked up to you for your clear thinking, pragmatic approach. And you're very sort of self-effacing and innovative. So let's start with, your career path, how you got into medicine, how you chose pediatric orthopedics, and this was at a time and in a place where, subspecialization, especially in pediatric orthopedics, was not that common. So could you take us through that journey?
Sure. I was born and brought up in a very middle-class family. My father happened to be a dentist, but had a very small practice, and we were in a hill station called Ooty, beautiful place.
Yeah.
I then did my schooling initially there, then went off to Hyderabad on a government merit scholarship. And then in 1967, I had the opportunity to decide what I wanted to do. And all along, somehow, I had some faint idea of doing medicine. And it was sort of encouraged by my mother, who had some health issues. And so I felt that maybe it's a good idea to do medicine.
Yeah.
So I applied to one medical college, which was the Christian Medical College, Vellore. And as luck would have it, I got selected.
Yeah, and that's very competitive, right? CMC Vellore is like one of the top-rated medical schools.
That's right. It's highly competitive, but I wasn't really aware of that.
I see.
I took it very casually, but it went well, and I was lucky.
Yeah.
And it turned out to be one of the best medical schools in the country.
Yeah.
The training was phenomenal, and the teachers were absolutely devoted. So it was something that really set my the standards, and the goal that I want to achieve was to try to emulate some of these teachers of mine.
Yeah.
I then finished my medicine and then went and did a obligatory bond, as they call it, in a rural area attached to a mission hospital.
Yeah. And
did a lot of general medicine and general surgery.
This is after medical school, Benjamin. Was that after?
Yeah, this is after medical school, after the internship.
Got it. Okay.
And there, I had to deal with surgical issues which the small hospital couldn't manage, and the senior doctor there would send off all orthopedic cases to me. And I had a Bailey and Love. That was the only book available at that point.
Oh yeah.
And I used to do close reductions and so on and so forth. I now shudder to think how I didn't run into complications. And then I thought,
yeah. By the way, can I interrupt you? Can I interrupt you for a second?
Sure, right.
So just for the listeners, so Love and Bailey or Bailey and Love was the standard glossy print British author textbook, right, of general surgery.
Yeah.
Got it. Okay.
Yeah. That's right.
Go ahead.
It had a section of orthopedics, but quite slim.
Yeah.
Anyhow, fortunately, we managed without complications. Thank God for that.
Yeah.
And then at the end of that, I had to go back to Vellore to work as a demonstrator in the Department of Anatomy.
This is Christian Medical College. Yeah.
That's at the Christian Medical College.
Got it.
And at that time, for the first time, I realized there was a tremendous thrill in teaching. And I found a lot of fulfillment in trying to simplify issues and to teach, try to help conceptualize issues which are difficult for students to understand.
Yeah.
And I found it very gratifying. So that then told me that maybe in the long run, I should take up an academic position. I then went for training to Kasturba Medical College at Manipal and did my orthopedic training there. And because of severe financial constraints, my wife and I moved to Kerala to a mission hospital, which paid quite well, and worked there for 1 year to pay off debts that had accrued during my training. Once that was done, I had the option to go back into academic work. And I was invited back to Manipal by my old professor. I then went back.
Was that Dr. Chaco?
Yes, that's right. It was Dr. Chaco.
Got it.
And he was a tremendous clinician, beautiful surgeon. And his outcome of surgery was always fantastic. The only issue that I had with him was, for example, if he saw a patient with Perthes disease, he'd then do a beautiful varus derotation osteotomy. The outcome was good. In another case, he'd do a Salter's osteotomy, and the outcome was good. And then I would ask him, why did you choose varus osteotomy in this patient and a Salter in the other? And he'd smile very nicely and say, well, and then leave the sentence incomplete. And I got the feeling that he did it on a gut feeling that this is going to work. And he was right in most instances. However, for a person in training, I found it a little unsatisfactory. I wanted to have a rationale for something. And this is what got me to ultimately write a book on decision-making in orthopedics.
Got it.
Because if you take a standard textbook and look at maybe pseudarthrosis tibia, you'll have beautiful descriptions of, Ilizarov, you'll have beautiful descriptions of microvascular transfers, and beautiful illustrations and an explanation of intramedullary rodding. But when a patient comes to you, how do you decide which one you're going to do? Which is optimal for that particular patient. And therefore, I tried to put this down on paper, and I enjoyed doing that. And the response was quite gratifying.
So were your decisions based on like literature or your clinical experience or a combo? Because literature, as you know, even now in orthopedics is not that robust in terms of the science. So how did and especially like I know you started the Perthes study group. So maybe as a follow-up after tell us about that too.
This was another area that I got involved, and I must thank Harry Kim for having launched the IPSG, the International Perthes Study Group, and I was one of the first to join. And we managed to lay down some guidelines, and most of all, to get more people aware of what was happening. So it for some strange reason in the west coast belt of South India, which is to the west of a mountain range called the Western Ghats, where Manipal is, the incidence of Perthes is exceedingly high.
Interesting.
We have no idea why it is so. We did epidemiological studies in the early 80s and published it. And showed that there was a tremendous difference between the East Coast and the West Coast. Why, we still don't know. The cause eludes us. But it gave us the opportunity to study the condition, because we used to see as many as one new patient with Perthes every single week.
Interesting.
That is a little less common now, maybe partly because there's some evidence to suggest that Perthes is on the decline. But more than that, a lot more orthopedic surgeons have come around in the vicinity of our hospital. And so probably some of that is being diluted that way as well.
Interesting. All right. So I know. Go ahead. Sorry.
No, my interest in pediatric orthopedic is largely because I love children. And for my master's in orthopedics, I had to do a thesis on clubfoot. So again, I was dealing with children and parents. And so I decided to specialize. And I must say that I was, to a large extent, responsible in my department to pushed the idea of subspecialization, which was not popular at that time.
Yeah.
And we were proud to say that we were the first institution in the country to subspecialize.
Yeah.
And I decided to take up pediatric orthopedics and started doing that. And then I got the opportunity to go and train with John Sherrard in Sheffield, which was a godsend. So I went there and then spent a year with him and a year at the Alder H. Children's Hospital. Did pediatric orthopedics and came back. I was funded by the Smith and Neville Foundation for my first year. And when the diplomas were presented to me by the Duchess of Gloucester, she asked me, "Will you be going back to your own country?" And I could honestly proudly and honestly say, yes, the minute my training is over. And that's exactly what I did. And I went back. And when I got back, the dean of the institution asked me, "Benjamin, what is it that you learned?" And I could again honestly tell him, we'd already started doing pediatric orthopedics. So when I went there, one of the most important things that I learned was we were doing a good job, and that reinforced and gave us confidence in proceeding. So that was how I took up pediatric orthopedics. And I enjoyed the years that I spent thoroughly. It was one of the most fascinating experiences. We saw tremendous pathology, and we had to cope because many of the patients didn't have money. And ours was a private institution, so it wasn't charitable. So we had to find the resources. And I took a decision at the very outset that I would treat any patient who comes to me, come what may, whether they had money or not. So I had to find the resources, which I did, fortunately. And thank you. I thank those who helped, and particularly, if I may be permitted to say so, I thank God for the opportunity.
For sure.
And one of the challenges was to work with limited resources. And that made me innovate and think more deeply. For example, when I came across growth modulation, and we had this wonderful 8-plate come out, I suddenly realized it's very much like the old Sherman plates that we used in the 1970s. No difference in terms of shape and structure, but only thing the material was titanium. So I said, well, we can't afford that. That's too costly. So I took a reconstruction plate, cut it in the workshop, got it polished, and started using it. And that's what we used for several years without a single complication. And the cost was less than 5% of the titanium material.
Now
when
you've
we came to
go ahead.
osteogenesis imperfecta, we again found it difficult to get telescoping rods because they were far too costly. And so we started doing dual rush rodding for the femur. And that stood the test of time. In fact, we still do it. So we've been happy with some of the innovations we made, and we continue to do that because it's cost effective.
I mean, and again, I think that's just shows your creativity back in those days. Like you mentioned, being, the colonial India that it was, that there was a lot of textbooks that were rooted in sort of, British and maybe some American textbooks. That was the teaching. And I know I sort of experienced that as well, that when we were looking at things locally in our hospitals, it was like, oh my God, so we must be substandard. But I think for someone like you who had the foresight to understand that really it needs to be, modulated and adopted for the local setting was really, was very forward thinking. Because you talk a lot about consumerism in medicine. And, nowadays there's this word that's thrown around, jugaad, or, frugal innovations. So tell us, you've told us a little bit about how you've been so creative with implants, etc. But let's just go back to the Pediatric Orthopedic Society, because I think you were of course, you were the past president of POSI, the Pediatric Orthopedic Society of India, and it's really taken off, I think, in the last 20 to 30 years in terms of the volume and the depth and the complexity of pediatric orthopedic that's done by the members. And if I'm not wrong, I think POSI is now the second largest pediatric orthopedic society behind POSNA. So can you tell us, and I know you made the logo for the society way back, so tell us a little bit about POSI, where it came from, where you think it's going to go, and that journey.
Yeah, when I got back from England in 1988, I was aware that Ashok Johari in Bombay was doing some pediatric orthopedics.
Yeah.
And I knew that Professor Sriram, the late Professor Sriram in Chennai, was doing some pediatric orthopedics.
Yeah.
So I said, we must start a society and we must propagate the subspecialty. And I wrote to them and said, how would you like to proceed? Because this is something we should do.
Yeah.
And the three of us were the pioneer,
founders,
the steering members of the committee that started this society.
Yeah.
And the first meeting we held was in 1994 in Bombay to start the society.
I see.
And the first annual scientific meeting was held at Manipal in 1995.
Yeah.
And subsequently, we went from strength to strength, and the youngsters got on. We found that people were really interested in the subject, and we really enjoyed serving our terms as presidents and so on. Now the youngsters have taken over, and I see a tremendous future in the society. And I'm sure that they'll do well. So yes, that was another enjoyable experience. It was worthwhile, and I'm glad we did it.
Yeah, got it. Now, how I know you've recently taken up art and pediatric orthopedics, and you've published a fair bit on that. So has that been an interest of yours all along, or is that something you're developing, in the past few years?
I always had an interest in art. For example, all the books that I've ever written, every illustration was drawn by me. So I've enjoyed art.
Yeah.
And I saw a particular article which is on clubfoot. There's a famous painting by Rubero, which shows a child with clubfoot, and that painting is in the Louvre.
Yeah.
In the museum.
Yeah, in France.
And so there was an article about it, and it tried to interpret what it was.
Yeah.
And questioning whether it was clubfoot, and someone suggested that it could actually be hemiplegic cerebral palsy. So I looked at that and said, that's very interesting. And later someone said it's polio, and we thought that wasn't an appropriate suggestion. So Hugh Watts and I sent a letter to the editor saying that we don't agree with that, and I gave our reasons. Once we did that, I looked at thousands and thousands of paintings of masters because I enjoyed looking at it. And I looked at that, came across some remarkable paintings which showed children with deformities. And the first one that caught my attention was a painting by an unnamed artist called the Master of Alkmaar, which showed food being distributed as for charity. And a person sitting on the floor because he couldn't walk was a person with polydactyly, which was shown by the artist remarkably.
Interesting.
And it was probably very rare congenital anomaly which we had seen, and I wrote about that. Then I kept looking more and more, and we actually published a dozen papers in the Journal of Pediatric Orthopedics.
Yeah.
And I would still continue to do that if I had the time.
Yeah.
So yes, that was another thing that interested me.
Got it. Okay. Well, I think we're going to run out of time soon. Any final words for the young surgeons, the orthopedic trainees, both in the Indian subcontinent and globally?
Yeah, one example that I would like to share is flat foot. When I was in England, I saw plenty of children with flat foot. I came back to India, I saw 6 in 2 years.
I see.
And I said, this is funny. Either people are not concerned about flat foot or the incidence is low.
Yeah.
And we did 2 studies which were published in the British JBJS several years ago, which showed that there was a distinct association between shoe wearing and flat foot.
Huh.
And we had followed the old British tradition of prescribing shoe modifications for flat foot.
Huh.
The studies of flat foot which we showed suggested that shoe wearing was detrimental to the development of the arch. And so it was totally counterproductive.
Huh.
So when we are in a country like India, humid, hot, suggesting shoe wear and modifying it for asymptomatic flat foot was ridiculous.
Yeah.
And so we tried to change the concepts, and it's very tough to get people to change.
Sure.
And I would ask youngsters to look carefully before prescribing or treating conditions which often doesn't need any treatment whatsoever.
Yeah. That's
I would end on that.
Okay, very fair. Thank you. Thank you so much, Benjamin. It's been such a pleasure and an honor talking to you. And
it was an honor too, Sanjeev. It was lovely talking to you. Thank you very much.
Yeah, pleasure. Take care.